here is the, I mean, to present in the innovation and diabetes management. So the problem here, the advancement in diabetes management is so huge. If you could see here, we get an advancement in insulin pump, and there are like so many insulin pump in the market where even they could separate the reservoir from the insulin pump, and it acts on Bluetooth. There are also just advances in continuous glucose monitoring and connected CGM with the insulin pump. Sorry. Okay. So there is what's called now closed loop, and there are so many new medication which is presented in the latest ADA. And there is also advances in the insulin innovation, or the insulin delivery system, or insulin itself. Like now, we have like recently the weekly insulin, which is iconic, plus the ultra short-acting insulin, like fast asp. And we have there is advances in glucagon delivery, that there is a glucagon which is easily to be used, like inhaler glucagon. And there is advances also in smartphone apps related to diabetes, plus in addition to meal delivery service. So since this is a pharmacology conference, I decided just to concentrate on diabetes medications and what is really just new related to these diabetes medication, and I exclude also just the insulin innovations. So I will talk about this new medication, which is tirzepatide, sortilozin, Fenrinon, Tablizumab, in addition to triple receptor agonist, and going through just evidence-based medicine, presenting their landmark trials. So here, this is the algorithm of medication, which is just presented by the American Diabetes Association this year. This is the ADA 2021 algorithm. And if you concentrate on the right side, you will find that the ADA has bought just like a new, which is like since 2 or 3 years, it indicates that the risk of cardiovascular disease. So now we don't concentrate in the management only on efficacy of medication, but we have to consider the establishment of cardiovascular disease and whether the patient is getting cardiovascular disease or kidney disease. And you could see here the main two new medication, new classes in this advancement is the SGLT2 and the GLP-1. And they are not really just a new medication, but the main advance in the last few years was mainly in this medication. And I chose this slide from meta-analysis for the SGLT2 inhibitor, which shows the landmark trial of this medication and their benefit on hospitalization, heart failure, in addition to major adverse cardiovascular event. And they will not go through this because this is not the latest one. This is already established. And we could see also just from this meta-analysis related to stroke that GLP-1 as a group, they have the same effect. And we have really just good data on leader trials, Sustain 6 and Rewind regarding the efficacy of this medication on cardiovascular outcome. So these two classes are extensively reviewed over the last few years. So here, what's new really? What's new regarding the diabetic medication? So I'll go through the 5 medication I've chosen, and I'll go through with this one, the first one, which is called tirzepatide. So what is tirzepatide? Tirzepatide is a dual glucose-dependent insulinotropic polypeptide. So it's a GIP in addition to glucagon-like peptide 1. So it's dual agonist, GIP agonist in addition to GLP-1 agonist. It's under the development for treatment of type 2 diabetes. This is the landmark study which was published on tirzepatide. So it was tirzepatide versus semaglutide once weekly in patients with type 2 diabetes. Why they choose semaglutide is that, it is the most widely used medication. It's just approved in our hospital. It's a strong medication from the efficacy point of view, and it's really an excellent medication, even for weight reduction. And this trial was just published this month in August. It was published online just in June. So it was appeared in New England Journal of Medicine on August 5th, 2021. So the main objective of this study to demonstrate tirzepatide on different dosage, 5, 10, and 15 milligram, are non-inferior to semaglutide 1 milligram. So with the secondary outcome being, to have a superiority on this medication on hemoglobin A1C in addition to weight reduction. So this is a randomized open-label, active control, parallel group, multi-center, multinational trials. They include patients with type 2 diabetes with hemoglobin A1C between 7 to below 10.5 at the screening, and their BMI more than 25 kilogram per square meter, and they have to be stable. They have to be on metformin on a stable dose, at least 1.5 gram. And they exclude patients with type 1 diabetes, or they get history of acute pancreatitis, or the estimated GFR less than 45 ml per minute per 1.73 square meter, or if the patient is using any anti-hyperglycemic medication other than metformin in the last 3 months prior to screening. So it's an open label trial. It is phase 3 trial. They were randomized to 1:1:1:1 ratio, and to either semaglutide as the comparator group versus tirzepatide 5, 10, or 15 milligram. The main result was the hemoglobin A1C reduction. There was a superiority in hemoglobin A1C reduction in all the 3 doses of tirzepatide as compared to semaglutide, with significant p-value. And if you look here to the percentage of patients who reach hemoglobin A1C below 7, it reached up to 92% in the highest dose of tirzepatide versus 81% in semaglutide group. And what's interesting, for those who could reach a hemoglobin A1C below 5.7%, almost 50% on those with the highest dose of tirzepatide, they reach such hemoglobin A1C of below 5.7% as compared to 20% on semaglutide group. So this is the mean hemoglobin A1C reduction. So in semaglutide, which is a strong medication for from efficacy point of view, to reduce hemoglobin A1C by a mean of 1.86%. All the 3 dosage of the new medication tirzepatide were superior to semaglutide, and the change in hemoglobin A1C was more than 2%, and it reached the highest efficacy with the largest dose of 15 gram to minus 2.3. On regard to body weight, all the 3 doses of tirzepatide significantly reduced the hemoglobin A1C more than semaglutide group, and in a significant p-value. And if you look to the mean weight loss, it was 5.7 kilogram in the semaglutide group with the maximum dose of 1 milligram, compared to mean weight loss in tirzepatide to 7.6 milligram in the lowest dose, and it reached to 11.2 gram in the highest dose of 15 milligram. And if you look to the side effect, they were comparable between the two groups, and it was mainly GI side effect. And if we look clearly to the hypoglycemia, bearing in mind that with the 15 milligram of tirzepatide, 50% they reach a hemoglobin A1C 5.7, less than 5.7, which is like a normal hemoglobin A1C. There was no increase in clinically significant hypoglycemia between the two groups or severe hypoglycemia. So the main result of this tirzepatide study showed in people with type 2 diabetes inadequately controlled on metformin monotherapy, once weekly tirzepatide, which is a dual GIP and GLP-1 receptor agonist, demonstrates superiority or superior and clinically meaningful improvement in glycemic control, significant reduction in body weight, normoglycemia less than 5.7% for hemoglobin A1C and up to 51% of participants with low risk of hypoglycemia, mainly clinical significance of hypoglycemia 54 or severe hypoglycemia. Now we'll go to the second medication to be discussed, which is sotagliflozin. So what is the unique about sotagliflozin? It is a dual SGLT1 and SGLT2 inhibitor. So we know that SGLT1 receptor, they are mainly primary transporter in the intestine, responsible for absorption of glucose and galactose in our GI tract, while SGLT2 is expressed in the kidney and responsible for reabsorption of 90% of the filtered glucose. So sotagliflozin is a dual GLP-1, so SGLT1, SGLT2, SGLT1 and SGLT2 inhibitor. So they will go to the evidence-based. So this is the trial on sotagliflozin in patients with diabetes and recent worsening heart failure. It was published earlier in this year in New England Journal of Medicine on January 14, 2021. So the main objective of this study to study the safety and potential efficacy in initiation of the double SGLT inhibitor 1 and 2 in patient with or after episode of decompensation of heart failure. So this study, it was, the initiation of sotagliflozin upon discharge or 48 hours after discharge. So it was a multi-center double-blind trial done in patients with type 2 diabetes with who are recently hospitalized for worsening heart failure, were randomly assigned either to receive sotagliflozin or placebo. So they include patients with signs and symptoms of heart failure. They require IV diuretics, stabilized off oxygen upon discharge with transition to oral diuretics, and they have to have high PMP or high NT-proBNP, and they have to have type 2 diabetes. They exclude patients with end-stage renal disease, or they have recent acute coronary syndrome, stroke, PCI, or they underwent CABG, or those with estimated GFR less than 30. So this is the consort diagram of the study's initial enrollment. More than 1,500 individuals. The one were randomized, the 1,222 individuals, they were either randomized to sotagliflozin versus placebo. And you could see here the 96% in both the group, almost they completed the study. So the primary endpoint is a composite of total cardiovascular death, hospitalization due to heart failure, and urgent heart failure visit. There was a 33% reduction, relative risk reduction in primary outcome event, which is the total cardiovascular death and hospitalization due to heart failure or urgent heart failure visit in sotagliflozin group with significant p-value. The absolute risk reduction was a 25 event per 100 patient years, and the number needed to treat is 4. So you need to treat 4 patients with acute decompensated heart failure to prevent one primary event, which is the total cardiovascular death or hospitalization due to heart failure or urgent heart failure visit. And this, the primary events for the composite of total cardiovascular death and hospitalization due to heart failure or urgent heart failure visit, it occurs significantly early in the study, as early as 28 days. So from the secondary endpoint, the total cardiovascular death and hospitalization due to heart failure were lower in sotagliflozin by 32% with significant p-value as compared to placebo. The main adverse event in sotagliflozin was mainly diarrhea in addition to hypoglycemia. So the sotagliflozin in Solocit WHF trial clearly support the rational use of sotagliflozin and perhaps other SGLT2 inhibitor in patients who have visited, who has just recovered from a bout of decompensated congestive heart failure. So this study goes along with the study of heart failure like WHF with SGLT2. So it supports whether to use the SGLT2 inhibitor or the dual inhibitor of SGLT1 and 2. Our third medication is called Fenrinon. So Fenrinon is the novel non-steroidal selective mineralocorticoid receptor antagonist with anti-inflammatory and anti-fibrotic effect. It's thought to have a higher potency and less hyperkalemia than the steroidal mineralocorticoid receptor antagonists like spironolactone or eplerenone. So Fenrinon has been shown to reduce urinary albumin to creatinine ratio in patients with chronic kidney disease treated with RAS inhibition, while having a small effect on potassium level, unlike the spironolactone. So the trial on Fenrinon was published also in New England Journal of Medicine in December 2020. It's called The Effect of Fenrinon on Chronic Kidney Disease Outcome in Patients with Type 2 Diabetes. So they enroll patients with who are diabetic to be either on Fenrinon versus placebo. They include patients who are aged more than 18 years, and they have to have type 2 diabetes with estimated GFR between 25 to 60, or they get like moderate elevated albuminuria with diabetic retinopathy, or severe elevated albuminuria, and they have to be on maximum tolerated renin-angiotensin system blocker with potassium level less than or equal 4.8. So they exclude any patient who had heart failure with reduced ejection fraction, NIHA class 2 to 4. They exclude patients with uncontrolled hypertension or those with hemoglobin A1C more than 12%, or those with kidney disease, other kidney disease other than the diabetic nephropathy. So the primary composite outcome is the kidney failure or sustained reduction of estimated GFR of 40% or less from the baseline, or death from renal causes. So there was the primary composite events occur in Fenrinon 17.8% versus 21.1% in a placebo group, with an 18% reduction of primary composite outcome in Fenrinon group. The kidney failure happened in 7.3% in Fenrinon group versus 8.3%, and end-stage renal disease happened in 4.2% in Fenrinon group versus 4.9%. And unfortunately, both of these reduction, they didn't meet the statistical significance. There was a numerical reduction in this event without statistical significance, since the confidence interval it cross one. So on regard to secondary outcome, the cardiovascular death, myocardial infarction, stroke, hospitalization for heart failure, the event was 13% for Fenrinon versus 14.8% in placebo, with a hazard ratio of 0.76. So there was a 24% reduction of all these composite and Fenrinon group. So hyperkalemia, it occur more in Fenrinon group, 15.8 versus 7.8%. The hyperkalemia, which required discontinuation of the medication, it was 2.3% in Fenrinon versus 0.9% in a placebo. So there was a well-documented hyperkalemia occurred in Fenrinon group. So what is the implication of this study? After this study, the FDA has approved Fenrinon for treatment of adult patients with chronic kidney disease associated with type 2 diabetes. Fenrinon is the first in class non-steroidal mineralocorticoid receptor antagonist indicated to reduce the risk of sustained estimated glomerular filtration rate decline, kidney failure, cardiovascular death, non-fatal myocardial infarction, and hospitalization for heart failure. So soon we will see, inshallah, Fenrinon as part of the management of patients with diabetic nephropathy. So we'll go to the fourth medication, and this is related to type 1 diabetes. It's called Tablizumab. So as we know, type 1 is an autoimmune disease caused by destruction of beta cell. So what Tablizumab is anti-CD3 monoclonal antibody. It's supposed to inhibit the effect of T cell on beta cell. So it's supposed to do a delay and decline in beta cell function, especially in patients with recently diagnosed type 1 diabetes. So the trial done on Tablizumab was published in August 15, 2019, which is about 2 years ago. It was a multi-center, randomized, double-blind, involved 76 participants. And these 76, they have to be either relative of patient with type 1 diabetes, or they get high risk of developing type 1 defined by having 2 autoimmune antibodies or evidence of dysglycemia on oral hypoglycemia on OGTT. So they were randomized either to have a 14 days of Tablizumab versus placebo. The primary outcome is the elapsed time from randomization till the clinical diagnosis of type 1. So as we see here, there was a delay of type 1 diagnosis in Tablizumab group. It was in a placebo 24 months versus 48 months. So there was a delay by almost 2 years between a placebo and Tablizumab. The other thing, the type 1 occurred in Tablizumab group in 43% of the participants, while in those with a placebo, in 72% of the participants. The hazard ratio was 0.4. It was statistically significant by doing the adjusted cost of proportional hazard model. The main adverse event in Tablizumab was lymphopenia and rash because it is a monoclonal antibodies.
Sorry, Doctor, 2 minutes, please. Thank you.
Okay, I'm finishing. Okay, so what is the implication of this study? It shows that 2 weeks treatment with Tablizumab delayed diagnosis of type 1 diabetes in high-risk population. The American FDA has discussed Tablizumab use for prevention of type 1, and they decline the indication to use the Tablizumab for prevention of type 1 diabetes, and requested the company or the sponsor for more information. However, there is an ongoing trial in USA about the use of Tablizumab newly diagnosed type 1 diabetes within the first 2 weeks to preserve the beta cell. Our third medication is a novel medication, still in a preclinical model. The trial mainly in rat. It's called the triple receptor agonist. So it has a GIP, GLP-1, and glucagon receptor agonist. It has been so this is a peptide with a triple receptor agonist. It has been shown in rat to be superior in weight reduction against liraglutide and tirzepatide. So it's a promising medication. If the clinical became, I mean, if there is no side effect on it on a human. So by this one, I'll end my talk, and I end my talk that the advancement in pharmaceutical medications is really robust. Especially there is like just a huge research on diabetes. And thank you very much for your listening.